Good afternoon, everyone. I hope you all are having a good day. I wanted to tell you all that as a class, as a whole, your class average on your last exam has increased significantly. So I wanted to say congratulations. This shows me that you are studying and you are working very hard for this class, and I am very proud of you all. I did want to address one key point with you before we move into chapter 27 today. There was a question on our exam that stated something like an individual had been brought in through the ED with anaphylactic shock after consuming some shellfish. There were a couple of different choices for you to choose the first right intervention. One of those was to maintain a patent airway. The other was to administer epinephrine. I want you all to keep in mind that when you sit for an exam, or specifically your NCLEX, your state boards, if one of your choices is to maintain a patent airway, that will always be the right answer. That is because you have to consider the information only that you're given, and then also you have to consider your ABCs. You can administer epinephrine all day long, but if you do not have a patent airway, you will cease to exist. You have to have a patent airway. You have to make sure that it's not blocked. You have to make sure that it's maintained. And then you have to make sure that respirations are adequate, that you are moving oxygen through your body. If you are not breathing, you're not moving oxygen through your body, you are not circulating that oxygen in your bloodstream, your heart will die, it will stop, and it does not matter how much drugs you give, you'll cease to exist. So please always know that that is always the first right intervention. So we'll move in to chapter 27 today. I have listed online that we will be discussing the different organs of the GI system. We will be discussing risk factors for GI disorders, and then we will be discussing GI disorders themselves. We will actually just be discussing common GI complications today, and then next Tuesday we will actually move into the specific GI disorders, their signs and symptoms, and their specific nursing interventions. So today we are just going to discuss the organs, the risk factors involved in developing some GI disorders. I will have you guys identify those lab values, that assignment that I have posted to a forum for today. I've assigned a lab value to each of you. I want you to define that lab value, tell me what it is, and then I want you to tell me what it is used in the diagnosis for, and then I want you to tell me the specific nursing interventions for that diagnostic test. And once that is completed, there is a very, very small case study at the end of today's post or today's lesson on Moodle. I just want you to read it and submit your responses to me, and I will review it and respond to you. Okay, so we're going to talk about chapter 27 today. We'll discuss the organs of the GI system first. Hopefully you all have that print off, the diagram that I have posted on Moodle. Hopefully you were able to access it and print it off. If you would like to fill it out with me as we move along, that would be wonderful, and then we will discuss the different actions of those organs involved in digestion. If you've already filled it out, that's great. Just follow along with me, and we will work through this hopefully fairly quickly. Here is my diagram. The first organ that we're going to discuss, of course, is the mouth, and then we will work our way all the way through to the anus. So the mouth is where we ingest food through our oral cavity, and then saliva is released to help soften that food. So saliva comes from these glands here. So there's two submandibular glands listed, and then there's this parotid gland listed. Those all release saliva into our oral cavity to help soften the food, and then once our food is softened, we then further break it down through an act called mastication. So mastication is just chewing. So once our food is softened and it's chewed, then it moves on in, we swallow, moves on into our esophagus, where the food is then further moved to the stomach through an act called peristalsis. Peristalsis is a wave-like motion from an involuntary muscle that acts to move a substance through an organ. So in this case, we are moving our food product through the esophagus down to our stomach. So once it reaches our stomach, it's located here, stomach acid mixes with that softened food product, and it mixes through that peristaltic action again, so it all mixes together to further break down that food so that we are able to absorb it. So once it's all mixed with our stomach acid, it then moves to the small intestine. So it moves down through here to our small intestine. Once it reaches the small intestine, a few different things happen. Water is absorbed into our system, as well as nutrients. So this water and the nutrients are released into our bloodstream, and it circulates throughout our body to reach our cells to help with cell nutrition and metabolism. So the food product then moves on through that small intestine, again through the act of peristalsis. And then once it reaches the end of the small intestine, it'll reach that ileocecal valve that's at the end of our small intestine. That ileocecal valve will dilate, and it will pass the food product on into our large intestine. So once it reaches our large intestine, a little bit of water is absorbed into our system, but primarily water and enzymes are reabsorbed by the large intestine. And then that water, those enzymes and bacteria that is located in our large intestine break down the remaining food product into waste. And so once that waste product is created, it is moved again through peristalsis down all the way the length of our large intestine, and then it reaches our rectum. So once it reaches our rectum, it is stored there as fecal matter, and then an act called gastrocolic reflex initiates the release of that fecal matter into our anus. So that's the very end organ here that we see on this diagram. So once it reaches our anus, you have the urge to defecate. Once the urge to defecate is initiated, hopefully that individual responds very soon, and then expulsion occurs, and that is our end product. There are a couple of accessory organs that are associated with our GI system that we didn't hit on yet, so we'll address those now. The first one is the gallbladder. It's that dark, small organ there that we can see. The gallbladder is a sac. It's attached to the lower part of the liver. That is where bile is stored. Bile is actually created in the liver, but then released into the gallbladder and stored there until it is needed for digestion. So the gallbladder can store about 50 milliliters of bile. Once the food hits our small intestine, that gallbladder is stimulated to release that bile. So that bile mixes with the food product in our small intestine to further help break it down. Then we will discuss the liver. The liver is this large organ here. It sits kind of next to our stomach. And it's located in our right upper quadrant of our bodies. It's essentially the filter system of our body. So it filters out damaged red blood cells and toxins from our system. It also, like I said, makes bile. Bile breaks down fat, by the way. The liver also stores vitamins. It stores vitamins A, D, E, K, B12, and it also stores iron. It also is a very vascular organ, so it receives blood from our intestines actually through the portal vein, and this organ can store anywhere from 200 to 400 milliliters of blood. Then we have our pancreas. our pancreas is this organ here. It's kind of gray. It's a long, thin organ. It sits behind our stomach. The pancreas's job is to excrete insulin and glucagon. The insulin is actually created in the islets of Langerhans within the pancreas. And then once it's produced, it's released into our system to help with our blood sugar levels. It also secretes enzymes, digestive enzymes. Those enzymes are lipase, amylase, protease, and trypsin. Okay, so those are the organs of our digestive system. So now we're going to discuss the effects of aging on our digestive system. So there are a few that we need to hit on. The first one would be dentation. So as we age, sometimes our teeth, they break down, they can be chipped, loose, missing. Sometimes people will have dentures. So chipped, loose, missing teeth or ill-fitting dentures all make the act of eating uncomfortable. So these individuals may be less likely to want to eat. We also then have weakened muscles as we age. So our muscles of our digestive tract and then our muscles of our sphincters are also weakened. So digestion slows. As well as if our sphincters are relaxed, we can actually have reflux. So if that sphincter at the top of your stomach is not toned, we can release stomach acid into our esophagus, which leads to esophageal erosion. It can lead to, of course, GERD. And then if that stomach acid is sitting in our esophagus and we cough or it's irritated, we can actually aspirate that substance into our lungs, which creates a whole nother realm of issues. Something else that happens as we age is our taste buds atrophy. So once our taste buds atrophy, we have a decreased sense of taste. So if an individual cannot taste food, the appeal of eating is probably going to be a lot less, so these individuals are less likely to eat. Something else that is important to keep in mind is to go ahead and help these, to encourage all of your patients to maintain appropriate oral hygiene. So if we brush our teeth regularly, if we clean our mouths regularly, the taste within our mouth is going to be much more pleasant. Our breath is less likely to smell foul, to have halitosis is what it's called. And so we are going to be more likely to eat if we have good oral hygiene. The appeal of eating is just going to be heightened. So something else that happens as we age is our stomach acid secretion after the age of 70 decreases significantly, as well as lipase secretion. So if we have a decreased lipase secretion, we would then have an increased chance of gallstones. So those are some of the risk factors of, or just some of the effects of aging on our GI system. So now we will discuss risk factors for GI disorders. And those include infections, inflammation, trauma, post-operative scarring, also known as adhesions, stress. So if we're very, very stressed out, like if we're in nursing school and we are extremely stressed, it's more likely that our stomach acids are going to increase. Stress does increase the production of stomach acid. And once that stomach acid production increases, we are at an increased risk then to develop a gastric or a peptic ulcer. Genetic predispositions, smoking, alcohol use, caffeine, chemicals, and such as chemo can all increase risk for GI complications. Rapid weight loss can actually lead to gallbladder complications. It may also lead to the formation of gallstones. Some other risk factors include hepatitis, drugs, Specifically, medications such as NSAIDs, so our non-steroidal anti-inflammatory drugs, can actually increase the risk of GI complications, primarily, again, gastric ulcers. Alcoholism can lead to cholelithasis, peptic ulcers, and then hyperlipidemia and trauma, I think we already discussed, are also risk factors for GI complications. So to prevent some of these complications, we would want to encourage our patients to maintain a healthy, well-balanced diet. So we would want them to consume fruits, vegetables, healthy proteins such as chicken, fish, pork. We'd want them to avoid the red proteins. And then we would also want to encourage adequate dietary fiber intake, which can be done through many fruits, some grains, whole grains. There are also dietary fiber supplements. You can take capsules, you can drink Metamucil. There are many different products on the market now that we can encourage our patients to use to assist with digestion. Also, we would want to encourage adequate oral intake of primarily water. Another issue would be when you feel the urge to defecate, it is very important that you respond to that urge as soon as you can. If you do not, you run the risk of becoming constipated. Once you become constipated, you strain when you defecate, and the straining action can actually lead to the development of hemorrhoids. So another preventative action that we can encourage our patients to take would be to maintain a healthy weight and abdominal tone. So if we are overweight and we have poor abdominal tone, we are more likely to develop a hiatal hernia, which then can lead to gastric reflux, esophageal erosion, and possibly aspiration again. Good hygiene, like we talked about earlier, good oral hygiene is important for maintaining a good appetite. And then also, we would want to encourage individuals to receive their Hep A and B vaccinations. That would just help to prevent against the contraction of hepatitis, which if we contract hepatitis, that can cause significant liver damage. So let's talk about a few GI complications. The first one we will discuss is anemia. Anemia is essentially the loss of appetite. This can occur for a number of reasons. Anorexia. I said anemia and I'm not sure why, but anorexia is the first GI complication that we will discuss. This can occur for a number of reasons. I'm sure when you guys think of anorexia, the first thing that comes to mind is your mental health class. You will think of anorexia nervosa, which is actually a mental disorder. Those individuals have an extreme fear of eating, an extreme fear of weight gain, and they are usually severely underweight and malnourished. They lose about, on average, 85% of their body weight. So this is an intervention we would need to contact mental health for these individuals. Something else that can contribute to anorexia would be depression. That would also be a mental health issue, and you would receive a mental health consult for that individual. Outside of the mental health realm, let's discuss some other risk factors for anorexia. Those would include poor intention, again, like we talked about. So if it's painful to eat, these individuals are less likely to do so. Stomatitis can be a cause of anorexia. So if we have ulcers, we have inflammation within our oral mucosa, it's less likely that these individuals are going to eat because it's painful. You can encourage them to eat cool foods, but specifically we would want to encourage them to moisten the oral mucosa. You can provide glycerin sponges. Also, drinking through a straw for stomatitis just helps that to be a much easier, much more pleasant act for these individuals, and is a great way to help their oral mucosa become moist. So if you have stomatitis, please encourage your patients to use a straw to drink with. GI diseases may also be a cause of anorexia. So if you're experiencing a GI disease, it's less likely sometimes that you will have an appetite, especially if you're nauseous. You're not going to feel like eating much. Um, and then our diminished taste and smell sensations with aging would also make it less likely that an individual would even have the desire to want to eat. So for these patients, we are going to want to inspect their oral cavity. So you're going to look at their teeth and you're going to try to assess, do they have good dentition? Do they have chipped, loose, broken teeth? Do they have ill-fitting dentures? If so, what are some interventions that we could do to help these individuals with that type of a situation? Do they have ulcers in their mouths? And if so, like we already talked about, what are those nursing interventions for that specific situation? You're also going to want to ask the patient if they have trouble with food sticking when they swallow. So when they are eating, if they have food that sticks in their esophagus or they cough a lot when they are eating, these are signs that they may be experiencing dysphagia, which is the inability or the decreased ability to swallow. So if you notice this in a patient, you would then want to receive a speech therapy consult, and that speech therapist would conduct a swallow study to evaluate if this patient is in fact experiencing dysphagia. So if you have a dysphagic patient, factors to consider would be to thicken their liquids, to ease in swallowing. We would also then want to have a soft or puree diet to aid in swallowing. So those are all considerations for dysphagia. You could also offer people that are suffering from anorexia their favorite foods, as long as they're not too spicy and they're not immunocompromised in any way. Encouraging their favorite food consumption just helps with their appetite. If they are nauseous, we can treat that with antiemetics, or we can use a less conservative method such as ginger. Peppermint helps to ease nausea a lot of times for individuals, and then lemon lime soda is also another great way to help with nausea. So the next complication that we will discuss is bloating and flatus, gas buildup within the GI system. This can be caused by a number of factors. It can be the result of surgery. So after surgery, an individual may experience decreased GI motility, and this is because during surgery, when the patient receives anesthesia, a lot of times they will give the patient a paralytic medication. This helps to totally relax the patient so that they are able to be intubated, and then their breathing is maintained by that CRNA. But also, those medications then stay on board in your system for up to 48 hours. And so the paralytic medication, it has a great effect on your GI system and also your urinary system, which we will talk about later. But it slows peristalsis, and so it kind of puts those bowels to sleep. So it can lead to gas buildup within the GI system. Something else that can contribute to that would be a mechanical obstruction. So if you have a blockage in your bowel, you could possibly have, just because of the bacteria that's breaking up the food product that's already there in the large intestine, that bacteria, one of the byproducts of breaking up the food product is gas. And so if you have a blockage there, you're not going to be able to expel that gas. Your abdominal cavity, your abdomen is going to distend and may be painful, and you'll have the inability to pass flatus. And then another cause could be, like we talked about, surgery, but not as invasive surgery, endoscopic procedures. So colonoscopies will oftentimes, they do actually cause gas within your GI system. You will have the scope inserted through your anus, up your rectum, and through your intestines. And when they are in there with that scope, they release air into the intestine so that intestine expands so that the wall of the intestine can be visualized. And then once that procedure is done, that air has to be re-expelled. They do try to compress just a little bit of that air as they're exiting the GI system. But then we would have that patient lay on their left side in the fetal position, so knees to chest, and that kind of helps to straighten out those intestinal muscles, and it allows for ease of expulsion of the flatus. Some other things that we could do for them would be medications. One medication that comes to mind is simethicone. Simethicone can help decrease in the production of flatus. Simethicone is also a medication that we commonly see prescribed for gastric ulcers. So you would ingest this medication prior to eating, and then that simethicone, it coats the lining of the stomach, and it specifically adheres to the bed of the ulcer, and it protects that ulcer from GI acid and any food product that would be irritating to it. All right, so let's talk about constipation now, which is another complication of the GI system. Essentially, constipation is the hard, dry, difficult to pass stool. It can be caused by many factors. The signs include hypoactive bowel sounds, a distended, firm, painful abdomen, and then sometimes we would see the passage of liquid stool from the anus. That just means that the water within the gut is passing around that impacted area, that constipated area, and leaking from our anus. So that is a common sign also of constipation that not many people are aware of. Nursing care for these individuals would include encouragement of adequate fluid intake as well as dietary fiber. We would also want to encourage frequent ambulation and movement for these individuals. Frequent ambulation helps to increase the active peristalsis in our system, which is also why it is important after a patient has a surgical procedure that we do get them up first operative day. So not post-op day 1, but day of operation. So you allow that individual to rest, and then you will assess their pain level. You will medicate them appropriately, allow them 30 minutes to an hour, reassess their pain level, and then you will have that individual sit at the side of the bed. Once they're at the side of the bed, you want to make sure that they are not dizzy, nauseated, and that their pain level is manageable. Once you've established that, you will have them stand, and you will assess the same things. You'll make sure that they're not dizzy. Dizziness can be a sign of low blood pressure upon standing. So you may need to evaluate what their blood pressure is once they're sitting, once they're standing. Again, evaluate if they are nauseous, and evaluate their pain level. If all of that goes smoothly and they are able to tolerate sitting and standing, then you would then have the patient ambulate, whether it be to the bathroom, whether it just be simply to the door of their room. You would have them ambulate there and back, and then you would have them do a little bit more every time. This helps the bowels to kind of wake up from that paralytic that they were given, and it helps to encourage peristalsis. Something else that we can do for patients that are suffering from constipation, if the more conservative methods are not adequate, we can give stool softeners, we can give laxatives, and then it may even get to the point that you may need to provide digital stimulation or digital extraction. So if the constipation is severe enough that there is in fact an impaction there, it may have to be digitally removed, which is something that you are able to do as a nurse. Also, other individuals that suffer from impactions would be people who have suffered trauma and now are paralyzed. These people often have what we call a paralytic bowel. So the active peristalsis is actually absent in these individuals, which means that these individuals are not able to adequately move food product, specifically waste product, it generally affects the large intestine on through their digestive tract. So you have to provide digital stimulation to encourage that muscle to push the food, the waste product further down, and then you would actually also have to help digitally extract the fecal matter. The last complication that we will discuss is diarrhea. So that's the opposite, obviously, of constipation. Diarrhea is the frequent passage of liquid or semi-liquid stool. It requires intervention if it is prolonged past, generally, they say 24 to 48, but generally 48 hours. So once you reach the 48-hour mark, we are going to consider some antidiarrheal medications such as Imodium, Lomotil, and even kaopectate may be adequate to help stop the liquid passage of stools. We're also going to want to monitor these individuals for fluid volume deficit. So you're going to monitor their INOs, you will monitor their blood pressure and their pulse rate and their respirations. And then we would also monitor their electrolyte values to make sure that they are not experiencing an electrolyte imbalance that needs intervention. And then if it's severe enough and it goes on long enough, we may need to obtain a stool culture to determine the cause of the diarrhea. So once we obtain that stool culture, hopefully that causative factor is identified, and oftentimes they will be prescribed an antibiotic. Something else that may help with diarrhea are probiotics. Probiotics are a great supplement that they introduce healthy bacteria into our gut that aids in digestion and helps with the passage of fecal matter. So those are the different GI complications that we discussed. I need you all to complete your diagnostic test assignment, please. Like I said, define the test. Tell me what it is used in the diagnosis for and the specific nursing interventions related to that diagnostic test. And then once you have done that, I will have you complete this small case study and submit your answers, and then you will be done for the day. Next class period, this coming Tuesday, we will be moving into chapter 28, and we will be discussing specific GI disorders at that time. So I will post a very small discussion, probably chat, to the next class period where you just give me a 1 to 2 sentence response so that I can take attendance again. Maybe it can get you thinking a little bit about something positive or something related to this class. And then we will move on into lecture, and there may be a few activities posted for you at that time as well. So the ATI assignment, the worksheet, opens today. You will also have your midterm worksheet available to you today. So please access those as you're able and complete those assignments. And I will see some of you in clinics or clinicals tomorrow morning, bright and early. I hope you guys have a great rest of your day. Take care. Bye.